My name is Nimish Mittal, and I'm one of the EDS physicians that work at Toronto General Hospital. And my title of talk today is I'll be chatting about advancing the clinical practice of Ehlers-Danlos syndrome in Canada, where we started the framework of the EDS clinic back in 2017, and what our plans and our ideas about research and improvement of clinical care are. So just to give you, I don't have any disclosures, and just to give you a relevant background of who I am, so I am a board-certified physical medicine and rehabilitation specialist. I'm not an anesthesiologist, by the way, and I come from the land of the Taj Mahal. That's where I did my medical education, so my entire medical education, including my residency, was completed in India, and after that I worked for some time in the United States. It was essentially around working in chronic pain, interventional sports and spine. And then in 2015, I landed in Canada. I have done 3 chronic pain fellowships spanning around physical medicine and rehabilitation, opioids, cannabis, and for the last couple of years, I'm an anesthesiology fellow, being a physical medicine and rehabilitation specialist. So I got lucky, and anesthesia program accepted me as their fellow. On the other side, administratively, I'm also a committee member of the pain working group for the International Consortium of Ehlers-Danlos syndrome, and I am also the newsletter liaison for the Regenerative Pain Medicine Special Interest Group of American Society of Regional Anesthesia and Pain Medicine. It's the largest subspecialty society of pain medicine in North America. So when I was given this opportunity to come and speak with this smart crowd here, I was debating with myself what medical topic should I be presenting on, and then I realized that you are a smart bunch of people who have a good, fair understanding of the medical symptoms, knowledge about their basic condition. So I thought rather I'll present to you about what our vision and goal about how we deal with the daily challenges of Ehlers-Danlos syndrome in terms of managing the lifestyle would be. So initially, the first thing, I'll be summarizing the barriers which are associated with the diagnosis, and then I'll take you through the clinical care pathway and the research which we'll be doing at UHN EDS. Some of this is novel research, is unpublished, so please don't avoid taking pictures and disclosing it somewhere else. That's the least I can say. And this is one of the best pictures I have taken from the EDS RCGP website. They have an excellent toolkit if you access online. And this picture kind of explains everything, why a zebra is a zebra. Why? Zebra. Yes, always, yes. So, but you know, most of the literature, if you would look at the literature going down to 50s and 60s, there's a lot of nosology which talked about chronic musculoskeletal pains and joint subluxations, dislocations. However, the newer breadth of symptoms which are associated with the multisystemic issues, be it about IBS-like symptoms, be it about weak pelvic floor. Can I use the mouse instead here? Yeah, be it about the weak pelvic floor, or migraines, or low BP and POTS, dysautonomia. That is what is interesting in this population. And at the end, what happens is that the physicians who don't really have an understanding and knowledge about these different symptoms, it takes a lot of time for them to come to reality, to understand the complexity of the situation, and then they feel overwhelmed. And this is what finally happens, is that we don't know. So this is finally what ends up happening is a delay in diagnosis. There's all kind of literature which tells you what's the usual average time taken for a patient to get diagnosed. And a majority of Ehlers-Danlos syndrome patients have a long history of engagement with multiple variety of subspecialists and providers. A lot of these interviews and assessments don't end on a positive note, and patients feel discredited, disbelieved. Whereas on the part of the healthcare providers, as I was saying, we don't get enough training about Ehlers-Danlos syndrome specifically in our medical school, and there's not much in terms of the complexity of situation which exists out there. So the healthcare providers don't really, a lot of them are skeptical about believing in this situation, and the ones who believe, when they start realizing the complexity of it, they get overwhelmed, and that's what kind of is not good. And then what finally happens is the patient starts thinking that it's all in their head. And it's stress. Yeah. Yeah. That's what patients are made to feel, is that that's the notion, is what I meant to say. And then, but interesting piece is that there's no healthcare pathway for the management of Ehlers-Danlos syndrome. And because what also happens is that not every patient presents with a complete plethora of symptoms at a single time. Symptoms evolve as the patients grow up. I've seen several patients who started having symptoms after puberty. I don't know what happens after puberty. Some kind of hormonal change strikes everything out. And then I've also seen few patients who were doing great until the childbirth. And once they start having childbirth, they start experiencing symptoms, and the symptoms evolve over time. It's not necessary that they would have joint-related symptoms to begin with. They may be hypermobile, but not necessarily be experiencing any difficulties because of their hypermobility. It might be some of their multisystemic issues that would start creating their problems. It could be headaches, it could be abdominal pains. So that's the reason why it takes a lot of time and delay in diagnosing these patients. However, thanks to the new era of social media, modern medicine, and a lot of patient advocacy groups and patients who have come together and advocated about their situation, the medical community has started. There's now traction, which, as Susan was telling, there's a huge traction now which is building up in the medical community. They're starting to pay attention, and we were recently at Ghent, which was the International Consortium of Ehlers-Danlos syndrome. I thought Roberto would be here, so I thought it would be good to include his picture. I got this yesterday from the consortium, but I think he's not here. And he's talking with Dr. Peter Byers. He's one of the most respected figures in EDS research worldwide. And yeah, but you know, the interesting thing, what I found in Ghent was most of the presentations were talking about how to diagnose the patients with Ehlers-Danlos syndrome. And they were literally, like, when I looked at their handbook about the presentations, there were not even 5% of the presentations which talked about how to manage it. What are the effective clinical guidelines to manage the symptoms? Nobody really talks about them, and there's not much research which is out there. And it's all hit and trial method. People, physicians try to treat it in the way they treat other situations where the condition might have different etiology and pathogenesis. So like a cookie cutter custom-made approach may not work, and it doesn't work. Most of you would know this picture from 2017, Dr. Eric Hoskins, because they've heard of patient advocacy groups. There was a big fanfare. EDS program was started at Toronto General Hospital, and it was an interesting time because the clinic was opened in April 2017, and that was around the same time when the new criteria for the Ehlers-Danlos syndrome came out, the hypermobility criteria. And then the clinic started getting a lot of complex patients due to the lack of clinical guidelines how to treat these patients. And as I was saying, the patients can have multisystemic issues. There were complexities in their treatment. Also, what was happening is the expectations from both sides, patient and physicians, were entirely different. From what I understand, patients thought it would be their one-stop center where they could get the entire care for a solution of all their symptoms and management. However, due to the lack of resources from the physician and the government side, it was only a consultation service with no longitudinal follow-up. So it was meant to be not a good recipe for a successful clinic. However, having said that, we should, I would definitely, we should realize that it was a huge effort to take this bang on, and Dr. Mendoza, Dr. Suamber and their team started the program, and because of their efforts, we were able to get where we are now. Yeah, so I missed these. Yeah, this was kind of like a complex problem which we were treating, and then this is what ends up happening. We were backlogged in seeing the patients, and that's not a good thing to go on. However, we tried to rejig everything. I came on board in May 2018, and then we have now rejigged the entire clinic. There's going to be a huge PR event probably happening later next week, where we would be opening we have revamped the entire clinic, the services, the website, and so on. It was also made possible because of the philanthropic support by a private donor. And so I'll just introduce you to the new team out here. Dr. Hans Clark is the medical director, and I'm going to be the clinical lead. We have a nurse practitioner, which is going to be working with us. Dr. Daniel Santamina is an exercise physiologist. He is well published. Recent publication was in Lancet, and which is one of the second most highly cited journal in the world. So his area is exercise physiology. They've had successful programs in cancer and cardiac rehabilitation. So we've brought him on board. We have genetic counselors, and then we have psychologists. We also brought in an exercise physiologist. We have posted a job for a dietitian because we also want to track that route as well. And then we have a social worker in the program. We were also able to get a few specialists in our team. Dr. Arnon Edler is the cardiologist who would be looking at the dysautonomia perspective. And then we have 3 GI specialists in our team. Dr. Louis is the head of the GI services at Toronto Western. And Dr. C has already been seeing patients for the last couple of years. The newest addition is Dr. Colleen Parker. She is a gastroenterologist, and she just completed her fellowship from UCLA in dysmotility. So she's going to be taking EDS on once she finishes her master's. And then we have a geneticist, a clinical geneticist. We also have respirologist. The last person here is Dr. Karen Murphy. I heard Susan talk about Dr. Farb coming on board as well in the past. I tried to contact him in the past, but it was never successful. So Dr. Murphy is a radiologist. He was the program chief at Johns Hopkins until 5 years ago when he decided to come to Canada. And then he has worked for his major research has been around Tarlov cysts and dural ectasias, which is, again, we believe are linked to connective tissue disorders a lot. And he's well published, so he's agreed to be on our board looking at a primary EDS from a neuroradiology perspective. And the other good thing which happened recently because ILC survey efforts is Dr. Clark was at a provincial neurosurgery meeting, and because of the data we got from you guys, we were able to engage the neurosurgery group. So to answer the question which someone asked here is that Dr. Eric Massacotti is the chief of the neurosurgery at Toronto Western. He's agreed to engage a neurosurgeon at UHN who would be looking after the patients with Ehlers-Danlos syndrome. Coming on to the approach, what we believe, this is a picture of Dr. William Osler. He's the father of modern medicine, and he always said that, listen to your patient. He's always telling you the diagnosis. If you look at, when I was a child, we had a GP who our family had for generations. They would know everything which existed in my family, all of the family-related illnesses. And so he was able to treat us very well, whereas what I think is that in this era of modern medicine and specialized medicine, we now have a little bit of a tunnel-based vision where we don't look holistically as a patient in perspective, and we are only dealing with the systems. So that thing's probably got to change, and what our goal here at the program now is. We've worked a lot on physician-based approaches. There's a lot of new data which is coming out that physician-based approaches are maybe not the best way to go, and there should be an equal engagement of stakeholders, patients. Patients should be educated, counseled, involved in the decision-making process. And I'm a huge believer that whatever happens, I should know what's happening in my body. Personally, if I would be a patient, I would want to know. And there might be some treatments which work better than the other, but in my situation, maybe I don't want to go that route. So that's what is just our that's what our philosophy now is. The goals we have for the patients is all self-management models, because what we believe is that we don't have enough resources, and I don't believe ever healthcare systems, social healthcare systems, can have enough resources to cover all the multi-systemic issues on a daily basis for the patients. So the best treatment approach would lie if we could find self-management models to help the patients manage their symptoms on a day-to-day basis. Because we know it's there's no cure at this point for this condition. I'm going to just chat about the clinical pathway and the research pathway here. So any patients who comes to us now with a suspicion of Ehlers-Danlos syndrome, we have the first assessment clinic now. We do it twice a day on a weekly basis, full day. I assess the patients usually, and I have a nurse practitioner with me. We also will have, starting January or February, another rheumatologist who will be joining in as a primary EDS physician who would be assessing the patients with us. So the clinic would then be 3 or 4 days on a weekly basis. And then depending on what our assessments show, if the patients will be triaged to imaging, it could be either cardiovascular imaging or radiologic imaging. We've also been able to engage the radiologists. We are in continuous talks with them to develop a specific protocol for patients with Ehlers-Danlos syndrome, specifically around the Chiari malformation, you can call it. You can call it atlantoaxial instability, ligamentous instability, but the whole point being that targeting headaches around the patients in Ehlers-Danlos syndrome, which can be due to several etiologies. And we're getting good traction there. We have not yet finalized the protocol, but I think it should be done in next, maybe by the new year, we should have a definite protocol on how we target that. And depending on the neurosurgical results or the cardiac results, we can send the patients for specialist referrals if required. If the patient needs genetic counseling, another thing we have done is in the past what we were doing is we were referring the patients to the geneticist for a repeat appointment and to be able to order the genetic testing. It was an unnecessary step with duplication of services. So we have cut down that step, and right at the first appointment, if we believe that the patient needs testing, we schedule it with a genetic counselor and we get the testing going. And depending on the results, again, we also send the patients for management and follow-up, which I'll just talk about in a bit. Most of the programs that we target right now are self-management programs. So we have developed a physiotherapy and a rehabilitation program, which I'm going to talk in the next slide. I'll just talk here a bit about the psychological management. Again, to help cope with the complex medical needs of these patients, we are trying to come up with a group as well as small groups, patient advocacy groups, support groups is maybe the long way to go in terms of how to cope and manage day-to-day complaints or symptoms that the patients have. This is the exercise physiology and also our dysautonomia program, which we are just still tackling on how to, what would be the best protocol in terms of delivering. Right now what we do is that I do the first assessment and the other EDS physician would be doing the first assessment. This would be followed by a physiotherapy assessment, which would be based more about function on how joint stabilization, coping mechanisms with the stress and others on a psychology side. But then this would be followed by a kinesiology assessment. So the kinesiology and physiotherapists would then on a combined, they'll come to a consensus if the patients need to go to any of these 3 routes. So there can be several factors. If the patient is not available in the Greater Toronto area, we would just give them a health and lifestyle consult. Our therapists and would also be willing to engage with their therapists in the community on how to treat the condition. And then we'll have a home-based and a facility-based program where the kin would be seeing the patients probably twice to thrice on a weekly basis and work around getting to a better position in terms of conditioning and lifestyle activities. We would also, this is our research and the clinical measures which we would be collecting on the side as well. Other important thing, like the most common problem patients face is their hypermobile joints on a day-to-day basis. I'll just, to just give you a little bit about how we are gonna deal with this. I've chosen shoulder as a prototype. We know that the stabilizers of shoulder joint include dynamic stabilizers like our muscles of rotator cuff, but there are static stabilizers which include the ligaments around the shoulder joint. So, and in the past, all our efforts and energy have been in kind of toning up or delivering some muscle-based care so that our belief is that if the muscles get strength, the joints wouldn't dislocate. But that is not true in entirety. Patients still continue to sublux their joints in spite of being able to strengthen their muscles. So we revisited the literature, and what we saw is that there are the important ligaments, if you would see, are the coracohumeral, superior middle, and the inferior glenohumeral. There are two other ligaments. The one is the coracoacromial and the coracoclavicular, not shown in this picture. And then they would be, and then there's the capsule. So usually what the surgeons do is that they target the capsule, and then they stitch up the capsule. However, it doesn't work very well in majority of the population. So we are already doing an anatomical study with the help of ultrasound-based precision medicine, where I'm working at the anatomy lab and with our anatomy colleagues to find out if we can specifically target these ligaments. The concept is we're going to try and bring the prolotherapy options back. In the past, the landmark-based prolotherapy was vague. It was not centered and specific to the ligaments. But what we're trying to do, probably, if our results are really good, we are able to target the ligaments very well. And if the basic science study shows positive results, we will then start enrolling patients in a trial and start working on some prolotherapy options. So we start first with the shoulder joint, but then we'll move to hips and so on and so forth, the knees and the other joints as well. Most challenging condition for us to treat, one of the most challenging, including headaches, is abdominal pains. And we all know, like, the most common causes include dysautonomia-related dysmotility. There could be a mast cell activation, or there could be a small intestinal bowel overgrowth. Right now, all the treatments are towards trial and error basis with diet, supplements. A lot of literature exists out there which talks about FODMAP, aka the 6-food prevention diet, but it is not specific to Ehlers-Danlos. It's based on the IBS, whereas as the new literature comes out, IBS is not similar to this presentation in terms of pathogenesis, what the patients experience. So we are trying to, as I was saying, we have Dr. Colleen Parker's enrolled. We also have a new smart pill study, which is offered down south as the gold standard to assess the motility. And if the patients are willing to go, we already have set it up, the smart pill study, where we can look through the entire abdomen and figure out if there's any dysmotility. And we are also working on some diet-based nutritional interventions. If you could also take a look at Dr. Haiti Collins, is a physiatrist, works out of US. She's very much interested into diet, and I personally like her approach very well. It's not the FODMAP diet, but a diet towards normal biases, which should be encouraged in the patients with EDS. So we have partnered with the nutrition science department here at Toronto, and we are trying to look at some histological models to kind of see if there could be something that we could find in the abdomen or gut which we could target in terms of treatment. In the meantime, what we have is we are offering the dietitian support to come up with a diet and nutrition advice for patients, what to avoid. Though most of the patients really know that, but it is essentially for the new patients who are not aware of this condition. Yeah, choking goes both here, and also we take it on the respirology side as well. There's some literature which says that vagal innervation and dysautonomia might be the ones which would be causing choking. So there's a kind of overlap there. Yeah. Lastly, as the research evolves, we will come out with patient handout sheets for everything, coming from diet to nutrition. We've also, as I was telling you guys, we have revamped our clinic. There's a new website which is coming up on the 7th of November. We will post articles, our research, and updates on it. Here I would also like to tell you that we have eased our referral process, and I would encourage everyone to go and take a look at the new website. It's more easier to understand, more patient-centric focused. You can figure out what kind of symptoms you would experience when you have Ehlers-Danlos. There's also a patient and physician education video on how the Beighton score should be assessed. There's a huge inter-rater variability in Beighton scoring as well. And what finally happens is, what I felt is that patients get confused. Sometimes I give patients a Beighton of 2, whereas the other physician might have given them a 7 or an 8, and it totally changes the entire picture. For patients, it is totally confusing. They don't know who to trust. For them, both are the same kind of physician. So it kind of models a lot of things. So we have put in an EDS video there by Dr. Joel Christensen, who's the head of the hypermobility committee at the consortium. And then the last thing is the ECHO program is the Extension of Community Health Outreach Program. This program is started in New Mexico by Dr. Sanjeev Arora to train the trainers. It is, we don't have the capacity and the capability to see every patient on a longitudinal basis in our clinic. However, so what the best way is to find out the pockets and cover all the catchment areas with the general practitioners who have a basic understanding of Ehlers-Danlos syndrome, so that they can manage the day-to-day conditions, and if the patients are not being able to manage with them, that's when they can come and see us. I have already worked in the Project ECHO. It was actually brought to Ontario by a couple of my mentors from the chronic pain side, and then there have been like 5 or 6 years we've been doing chronic opioid stewardship in ECHO. So this is the other thing which we want to develop here in Toronto to train all the general physicians. We have a lot to deliver as of now. However, our long-term goal here is to provide services to other related connective tissue disorders. Right now, I see a lot of patients, I got an email yesterday from a patient who I diagnosed with Marfan's clinically. They came to us with Ehlers-Danlos, had a classic clear-cut picture of Marfan's, and then we arranged for the genetic studies. Unfortunately, we couldn't provide them with the physiotherapy access because as per the law and the government clinic regulations, it's only for EDS. So we would like to extend it in the future to all the other syndromes, be it Loeys-Dietz, Marfan's, osteogenesis imperfecta, and so on. The other thing what we are also want to do is we want to have standardization of clinical treatment guidelines. I'll just give you a small peek here. If you would see on your left side, here. So on your left side, this is about hormonal changes and about contraception in Ehlers-Danlos syndrome. The one on the left side is by Dr. Claude Hamonet. He's a French physiatrist. He's been working in EDS for 35 years. He's got 2 published books on EDS, and his data from 86 females said that when the disorders are treated by either progesterone-only pills or combined treatment, patients report symptoms improve. Whereas Dr. Alan Hakim from UK, he's also a big-time EDS researcher. His data from 2013 says exactly the opposite thing. They say that they might be better avoiding the pills which contain progesterone. So it also leaves us nowhere. The physicians also get confused about what to trust and what not to trust, and how to deal with the situation, because it's different for every patient. So we would like to standardize that as well. And our goal is to provide best evidence-based treatment and to develop Toronto as a global hub of clinical care, innovation, and knowledge science discovery. Thank you so much.